Perfect. Thank you. All right. Welcome, everyone. This is the 10th Rule Advisory Committee meeting for House Bill 3046. You should have received some materials before this meeting. I believe they were sent last Thursday, and they included the new draft rules, as well as some comments from Health Net of Oregon. We will be reviewing the comments from Health Net today when we review the draft rule, but I'd also appreciate it if RAC members can take some time to review those comments and provide me with any written feedback by Monday, July 11th. So written feedback to those comments would also be helpful. We did not receive any comments from RAC members, so we'll be starting the meeting with an overview, a brief update on the review of reports received from insurers. If Tasha is on the line. Tasha, are you on the line?
I am. Hello, everybody. So we have been working through the reports that came in April. We have kind of we've broken it down into two parts. The first part one is the data, and part two is the NQTL kind of written documentation. And I'm going to talk about them separately because they're two kind of groups of people working on them, but they're going on simultaneously. So insurers are kind of hearing from these groups simultaneously. So as it relates to the data piece, we have pulled together, and just this morning we met with Brooke and the policy folks to share the data that we, kind of the preliminary information that we are getting and what we are seeing. We need to follow up with some questions to some of our insurers about what they reported in that data before we kind of finalize it. And we are talking, so just to be really clear to insurers, we are talking internally about what level of the data would be appropriate to report this year. And we know that this year is probably pretty far off to do some kind of public facing, just like release of the data dashboard that we have. And that may be a goal for us to work toward in the future. However, this year we're going to find a way to aggregate and likely make sure that you know, an insurer wouldn't be named, but to release some of the information that we find from that data that is particularly helpful or insightful based on either testimony or feedback that we've received as part of this rulemaking advisory committee. So we do have some more data follow-ups to do with some of our insurers just before we kind of consider that, I don't want to say clean data, but it kind of wrapped up for this year. And we are working and kind of thinking about a list of changes to the data reporting to get better results and to clean up some of the kind of holes that we assumed we would find that first year in the data. So we are working on that process, getting ready for next year's report. So that's kind of the data bucket. The other bucket is the NQTL bucket, and we have worked through some of the information, I guess, that has been provided to us from the insurers. And we have sent out a list of questions to those insurers, and we have started to receive responses. I can't remember exactly what date I made those due by, but it was like 10 days from when we sent them. So by the end of June, we will have those. But that is where we are at on the data and the NQTL piece of the previous report. So any questions? Any questions that I can answer easily? I will probably in the future, like I said, once we get stuff cleaned up and get it scrubbed of insurer identifying information for this first year, we will be releasing some information, and I can come back and present to this RAC as part of that. Nothing?
Any questions for Tasha? All right, hearing none. All right, so we'll move on. I just wanted to mention up front, we have a pretty light agenda today. We will be reviewing the draft rule, and then there will be some time for public comment. At the last RAC, I know we had talked briefly about including a topic on today's agenda regarding the training of providers on the level of care placement guidance issued by the various nonprofit agencies, but we decided to move that to a future agenda as there is a group that is looking into this issue and working on it right now. And we're not quite ready to have an in-depth conversation about it with the RAC. So that could be something that we have on the next agenda, but we won't be discussing it today. So any questions before we get started? All right, Karen, do you mind pulling up the draft rule?
Forgive me, this is Chris. I just raised my hand. I have a quick question. Who is working on that?
I didn't see you. Go ahead.
It's all right. I'm just curious who's working on that.
Yeah, sorry, I didn't see your hand. So Tim Clement and Dan Toma and Bennett Garner are all working on that. I believe last I talked to the three of them, including I also spoke to Rachel Emery last week. Tim was looking into some data, and then he was going to circle back around to Bennett and Dan and have a further conversation, and then perhaps have a conversation at the next RAC. I don't know, Tim or Dan, if you have anything to add.
The plan is to reach out to a wider group before we, before including you, Chris, before we bring forward any proposals. So we're just trying to sort of kind of scope out what the concerns are right now, and then bring additional people in who we feel have a particular stake in making sure this works smoothly.
Thanks, Dan. All right, any other questions before we get started? Go ahead.
No, this is Tim, just saying that, Chris, this is what we talked about last week when we spoke.
Yeah, I gathered that. So I didn't want to belabor the conversation that we'd already spoken, but it sounds, yeah, thank you.
Okay, got it.
Any other questions? All right. So we will review the draft rule. This is the rule up on the screen. So starting with the 836.053.0012 rule, there were no changes made to this, so we can go down. The next rule set included on the list is the 1403 rule. We did not make any changes to the 1403 rule either. So we can actually scroll all the way down to the 1404 rule. All right, so in the 1404 rule, starting with 1A, I did add the 10th edition of the ICD as well, based on feedback from the last RAC. So now the rule has the 10th edition of the ICD as well as the 11th edition of the ICD. There was a question here from HealthNet of Oregon. They requested that there's further clarification on whether intellectual and developmental disabilities are included. The example that they gave is Chapter 5 of the ICD-10 covers mental, behavioral, and neurodevelopmental disorders, and that the title suggests that the scope of the chapter is broader than mental and behavioral conditions only. Subchapters that address conditions other than mental health and substance use disorders include disorders due to known physiological conditions, intellectual disabilities, and pervasive and specific developmental disorders. And they asked to consider providing further clarity to the state's intended scope for this definition. So my question for the group is, would further clarification be helpful here? And if so, what additions to the language would help?
This is Dan. I can provide a little bit of context. So the language that we have here, basically, we took that from. Oh, actually, sorry. I was going to say we took that from the rule, but this is the rule. We took language from the rule into the statute to define behavioral health conditions. And this was something that was worked out, I think it was around 2015 when the rules were updated. At that time, there was quite a bit of discussion around how broad or narrow the definition of what was then mental or nervous condition should be. And it was clear from the context of that rulemaking that IDD is included in that definition. I would agree that the language is a little bit vague in terms of what is a mental or substance use disorder covered by these diagnostic categories, but the history of that rulemaking, and I think the way it's been applied, has definitely included IDD. Chris, you were there too.
Do you think that there? Oh, go ahead.
Dan, I don't have anything. I think you hit it. Yeah, I mean, that came about at I think, Dan, if I remember right, the discussion around applied behavioral analysis and all that stuff. So that it was more inclusive than exclusive.
Yeah.
Are there any additions to the language here that would be helpful, that would make it more clear?
I don't have any to offer.
Okay. And again, the comments are included in your in the materials that were sent out via email. So if something comes to you later, please provide some written feedback for us. That would be helpful. All right, so that was the only change that was made to the 1404 rule. So we can move on to the 1405 rule, which is where the bulk of the changes were made. Right, so the first change is to 1, and I think I talked about this last time, which is in that last sentence, we changed the word qualitative to quantitative in front of limitations. So now it says any quantitative limitations must comply with the predominant and substantially all tests. And then there were some additional comments from HealthNet on number 2 and number 3. These are the ones, I think they're taken directly from statute, which require insurers to use the same methodology to set and update reimbursement rates. The question or the comment from HealthNet Oregon was a request for further clarification because there's a concern there's not currently a model or clear guidance for how to document that insurers are using the same methodology to set and update reimbursement rates. And the request is guidance to provide clarity regarding the state's expectations with regard to how to frame the analysis and which specific details must be addressed. So do others on the RAC have comment or thoughts on this, or any comments on additional language that would help to clarify this? I see a hand. Melissa.
Hi. So we just want to representing OIMHP here. We just want to emphasize that the legislative intent of HB 3046 puts the onus on the insurers to prove compliance. That's what the intent of the reporting requirement, and we don't think that it needs to be on federal or state regulators to determine exactly how an insurer is going to do that. Maybe this provides an opportunity for insurers to examine their methodologies and, to remedy any complications that would make it difficult for them to show whether or not they are in compliance. We also want to add that DCBS already conducted a big study for SB 860 that found many cases of non-equivalence in the way that insurers were reimbursing medical versus behavioral health. That they found that in the study, 91% of carriers used the CMS RVUs as a foundation for determining their medical surgical reimbursement, while only 40% of carriers used this same method. And so we feel like there's already been, it's already been established that there's non-equivalence, and we really don't support any further delays such as forming a work group or waiting for the feds to provide guidance. We think that there's enough in HB 3046 to kind of put the onus on insurers to prove their compliance.
Thanks, Melissa. Any other thoughts from the group? All right, hearing none, I'm going to move down. There was an additional comment on 4G. All right, so again, sorry, there was a comment on 4F and 4G, so we'll start with 4F. This language, again, is taken directly from statute, and the comment from HealthNet is a request for further clarification of the requirement, including the terms any level of care of placement. Their questions are there quantitative limits? Is utilization management prohibited? What scope of utilization management is permitted? Does this provision mean, for example, that long-term care residential treatment must be covered in acute care hospital settings? So again, this language is taken directly from statute. So do those involved with the drafting of the bill have any clarity on the intention of this section, or is there any thoughts from the group on the comments from HealthNet? Chris.
Well, I mean, to their question on utilization management, the statute and rules are pretty clear. So I don't think there needs to be any more clarity there. The intent is, again, in keeping with the findings in WIT versus United Behavioral Health, is to not artificially cap the duration of treatment based on some vague guidelines or number of set days that may be developed internally by proprietary guidelines, right? The intent of this whole thing is to say, hey, using clinical judgment and clinical instruments, you get a level of placement and a duration of treatment that's consistent with your continued findings in those diagnostic instruments. So I'm just not sure why. I don't know. To me, it's pretty clear. But like I said, I mean, I think the utilization management side of things is pretty clear in statute and rules.
Thanks, Chris. Dan?
Yeah, I agree with Chris. I think the intent is pretty clear, and there's nothing in there that prohibits utilization management. There's nothing in there that requires that residential treatment be covered in an acute hospital setting, which seems like an oxymoron. So I'm not sure that there's additional clarification required.
Thank you, Dan. Any other thoughts on 4F? Right. So 4G, the comments, again, requesting more clarity on the meaning of the phrase other outpatient services, specifically the intended scope of that coverage. And their questions are, is coverage for any outpatient service of any kind sufficient to satisfy this requirement, or does this provision require coverage for all outpatient services that are clinically indicated for the individual and not experimental or investigational? This is codifying what is already in statute, but I don't believe the language is taken directly from statute. So my question to the group is further clarity needed on this section, and if so, what would be helpful here?
And I think in the context of the entire law, to me, again, it's clear that, yeah, if an outpatient service that's a covered service and it's clinically indicated and it's not experimental and investigational, it seems to me that we would be required to cover it. It's not like
Yes,
you can say,
yes.
well, we offered some other outpatient service other than the one that was clinically indicated, so we're compliant with the law. I don't see how that would be a viable interpretation.
Thanks, Dan. That's how I read it as well. Are there any other thoughts? Okay, moving down to 8B, I believe, is the next change. This is the section that added, this is the section on utilization and other clinical review. The change to 8B is that we removed the effective date on 8B and also on 10B as a result of the conversation at the last RAC. And then in 10C, we removed language requiring the review of other criteria and added language indicating that if other criteria is utilized, that it must be made available to the department upon request. Any thoughts about those changes? Melissa.
Yeah, I just had a question. So on 10C, that part that you just said was added, other criteria utilized must be made available to the department upon request. I'm wondering if the same sentence should be added to the end of 9, which deals with decisions not related to level or non-level of care placement decisions. I'm just wondering if there's a reason why that sentence is under level of care placement decisions and not under non-level of care placement decisions.
I believe it's because the level of care placement decisions is the area where other criteria, it has that carve out in the statute where other criteria may be utilized. And for other utilization or clinical review, it's pretty clear in the statute that it has to be related to the generally accepted standards of care and doesn't necessarily allow that carve out. And I can pull up the statute if you guys would like to see that specific language. Would that be helpful?
Yeah. I mean, I know this is the kind of the sections that were up for a lot of debate, and I know that we've cut out the part about prior approval. So I guess I'm just, yeah, and I would have to look at it. Just wondering. So this statement says that the other criteria must be made available upon request, but that doesn't mean prior approval. And so if there's a reason why that can't be done for non-level of care placement decisions, I would love to see that for clarification. Thank you.
And Jen, I see your hand up.
Hi, Brooke, thank you. I just want to clarify one thing, and Tasha, hold me to the fire if I am wrong on this, but the DFR can request information from insurers at any time. There's pretty broad authority there. I feel like, first of all, I want to thank you for complying with the statutory granting authority and removing the language that requires review and approval from the department. I had no problem with you adding the language on other criteria must be made available to the department, because the department can request data from us at any time that relates to compliance with insurance laws. So I do feel like this language is put in there solely to kind of accommodate some of the concerns or neuroses, if you will, of some of the advocates. But I mean, regardless of wherever you put that language, the DFR can request data related to compliance with the law. So just want to.
Yeah, you're correct. And Tasha, you can add if you want to, but we do have pretty broad authority to request data.
While we do have pretty broad authority to request data, I would be dishonoring my team if I didn't say that it is easier for us to get compliance with the data requests if the request is laid out as a statute or a rule. So if we have like a basis that lays it out or a bulletin, sometimes we use product standards for this purpose. Oftentimes it's easier to be able for us to be able to say like, this is something we've discussed and here it is in statute. While we are all here right now in this space and Jen and I can like recall on each other and use each other's memories, eventually we are all hopefully going to retire and go on to a retirement home and relive all of this together. But somebody will be there to replace us. And
I'll be there first. I'll say you'll be
But somebody's going to have to replace us. And I just think about them specifically, like trying to piece this back together. So if we have it in the rule.
I agree with you, but I mean, like, even let's just say for example's sake that you didn't have that language that says other criteria utilized must be made available to the department upon request. And if you wanted to review non-level of care placement criteria from an insurer and you cited the same statute or the same rule, 10C, I mean, even without that language, you still have the authority to request it, right? I mean, so again, it's fine. I'm totally fine with the language, and again, appreciate the DFR working with us on this. But I do think that even if you just cited the rule in your request without that, we would have to comply. I don't see any other way around it.
Thanks, Jen. Thanks, Tasha. Rachel?
Thanks. I just wanted to flag that the statute says that for non-level of care placement decisions, that criteria must be made available publicly, made publicly available and provided to insureds upon request. So it feels like it's not a huge add to add the sentence from 10 up to 9 so that you guys can formally request it through rule. Thanks.
Thanks, Rachel. Does anybody have any thoughts about adding it onto 9?
I don't have any concerns with that.
No concerns from Providence.
None from Pacific Source.
Melissa, I saw your hand go up and down. Are you?
Sorry.
Do you want to say something?
Yeah. I was waiting this to play out. I did, and then I didn't. But no, I was just looking at the required disclosures section, and I don't know if that's what Rachel was referring to. And it's helpful to hear that this is something that can be requested, but that's the reason why I asked, mainly because the way that I'm reading it, if I'm taking everything literally, it says the information must be made available free of charge to any current or potential enrollee, beneficiary, or contracting provider upon request, but it doesn't say anything about the department, and so maybe that's just already a known entity, but I just noticed that it didn't specify the department, and that's why I just wanted to ask for that consistency, that if it's under 10, it would, be nice to see it under 9 as well.
Thanks, Melissa. I'm hearing no objections to it, so I think on the next draft we'll add that sentence there as well. In the 1408 rule is where you'll find language on disclosures made to other entities, to enrollees and other entities besides the department. I think that's what you just mentioned, Melissa. All right, so moving down, was there another comment? I'm sorry. All right, so 10D, this was just slightly reworded so that it was more consistent with our other rules and with statute. And then in 10A through D, these big A through big D. And this is the section where the nonprofit guidelines are listed. And based on the conversation from the last RAC, I did do some research into the current versions of those guidelines that are being utilized, as well as where to locate them. And so where there are versions available, those are now listed in the rule. So for instance, for A, for the ASAM criteria, it currently says 3rd edition 2013, and then there's a website listed for where to find information on that criteria. There's also a version for the locus. I could not locate specific versions or dates for the cow locus or the ECSII, but I did, again, put the website of where to find that resource in the rule. And so my question for the group is this sufficient, or is there more information that needs to be added to this section? Does anybody have any thoughts?
Well, again, it's a small point, but the locus can also be used for addiction for adults. I don't know that anybody does it, but you know, and it might just confuse things, but if you're following the statute to the letter, that would qualify.
Thanks for that, Bennett. I also was curious what people thought about adding the associated web links to a website somewhere, perhaps on a resources tab on our 3046 website. Do you think that that would be beneficial as well? Oh, hands. Gary, go ahead.
Hey, Brett, this is Gary, Pacific Source. Looking at this rule, I'm thinking here that, do we really want to put websites in a rule? I think it may be better positioned if we put it on the division's website for 3046. I think it's good that we call out the version and the association, but website specific, because if they ever change, then someone can come in and say, okay, well, you need to update your rule to reflect the new website, especially on sites like google.com. I would put out there that, we take the web page citation and put it on the division's website as opposed to having it into a rule.
Yeah, that's a great point, Gary. Perhaps we could indicate somewhere in the rule that this information is available on a website, and then put it on a resource tab on the 3046 website. What are people's thoughts about that? I see a thumbs up. All right. So any other questions or thoughts about this section? I heard somebody say my name. All right, hearing nothing. Maybe I'm just hearing things. It is a Wednesday, it could be. All right, so moving down to 12. This is the section that talks about the training that's required by statute. And I think it's 12A. We did add other entities authorized by the department. That is the language that is specifically in statute. So it would be the training must be provided by nonprofit clinical specialty associations or other entities authorized by the department. And my thought around this as well is that it's actually the nonprofits who contract out with other entities to provide this training. But if we do add a resource section to the 3046 website, we could list the other entities that are currently authorized to conduct the training on the website as well. Do people have thoughts about this change?
This is Dan. I support it, given that that's how the locus and cal locus are, that's how training for those is generally offered.
Yeah, and this is Ben, and I would support it too. And I've talked with Ken Minkoff from the American Association of Community Psychiatrists, and they got some convoluted way to deal with this, but it would be more straightforward the way you've got it here.
Thanks, Bennett. Thanks, Dan. Any other thoughts? All right, those are all the changes to the rule. I do see a comment asking, let's see, where was it? Dan, at an appropriate time, can we go back to 4A and 4B? So you're talking about 4A and 4B in the 1405 rule, is that correct?
Yes.
Okay.
So if
Let's
I can
scroll back
find
up.
that here.
All right. I think you can go back down, Karen. This is the correct rule set, and then 4A and B. So do you have questions about 4A and 4B?
I do. I think the landscape has changed completely from when these two paragraphs were first put in rule. And so these, I think, were intended to, say this is how you're going to figure out compliance with the quantitative treatment limitations under Oregon Parity. But federal Parity has really superseded that. And the language in subsection 1 that requires us to comply with the predominant and substantially all tests is really what's determinative of compliance at this point. And given that the substantially all and predominant tests are weird and produce weird results sometimes that might on their face look non-compliant with 4A and 4B, I think it's worth considering whether we should remove 4A and 4B altogether and have a single source of how we determine compliance with those quantitative limitation requirements.
Yeah, and this is Tim. I would support that concept. I think that just having one compliance standard that really mirrors, that's under the federal substantial law predominant tests for quantitative treatment limitations and financial requirements, I just think that would make the most sense now in the year 2022. So I agree with Dan.
So question, if we removed 4A and 4B, would the single source be that sentence in 1 that talks about the predominantly all? If you can go back up to 1, Karen, sorry. Okay, so that last sentence that says any quantitative limitations must comply with the predominant and substantially all tests in the federal act. Is that the single source, or would we need to add new language?
That would be the single source.
Yeah, that's a single source. And I would just recommend, though, that you change that citation 29 USC 1185A to 42 USC 300 GG-26, because that's the public health service. That's the part of the law you're allowed to enforce. You can't enforce 29 USC.
And which one did you say? 42 USC?
Yeah, that would be 42 USC 300 GG-26.
Okay, thank you. Does anybody else have any thoughts about removing 4A and 4B and keeping in this sentence around the predominant and substantially all tests?
I just think a quick question for Dan and Tim, for those of us uninitiated in the technical side of things, the application to co-pays and that kind of stuff is encapsulated in this. Could you just describe that briefly?
Yeah, sure. So the way it works is that if you're gonna, in order to determine if you can, let's take copays. To determine if you as an insurer are allowed to apply a copay to mental health or substance use disorder benefits, you can only do that if you apply copays to at least 2/3 of medical benefits in the same classification. So if we're talking about, you know, outpatient office visits, if you're applying copays to only 60% of your outpatient office visits for medical and surgical, then you are not allowed to apply a copay at all whatsoever. However, if you are applying at least to 2/3, let's say it applies to 75%, then you can apply copays to mental health or substance use disorder. However, the copay you must apply has to then pass what's called the predominant test. It gets a little complicated, and it's hard to explain, but it's one of those things where once you see it, it's pretty easy to grasp. But once you're allowed to apply, let's say, a copay, you can't apply one that's more restrictive than the copay that applies to at least half of benefits that are subject to. If you've got a $20 copay, a $30 copay, and a $40 copay, and let's say the $30 copay applies to 60% of the benefits that have a copay associated with it, then that's the most expensive copay you're allowed to use. You can use the $20 copay too, but you can't use anything. You can't use the $40 copay for mental health. But anyway, sometimes though there will be situations where you will have an instance where the mental health copay is not the very cheapest copay that exists, because there might be a level that is applied to more than 50% that's more expensive than. So for instance, under the example I just gave you, you could apply the $30 copay to mental health and substance use disorder, and then you could still have instances where some medical benefits that have the $20 copay. And so you say, oh, wait a minute, there's a cheaper copay for medical benefits than some of the ones for mental health and substance disorder. That's illegal. It's actually not, though, under the rules of the substantially ill and predominant test. But usually it ends up being that the cheapest copay is the one that applies to more than half. And a lot of insurers also just end up applying the cheapest copay or co-insurance to the mental health benefit to make it easier for them to pass the substantially ill and predominant test.
Great, thank you, Tim.
Any other thoughts about this section? Oh, I see a hand. Gary, go ahead.
Yeah, so is the recommendation out there to remove number 4 there completely? If you're taking out A and B, would you pull it all out? If it is, I would support that, because I'm not sure if it's good to leave just 4 in there if there's no A and B.
Yeah, I think the original suggestion was to remove 4A and 4B, but I see what you're saying, and so
well, there's still C,
we would look into,
and
there's still C.
D and E,
and there's also
and F and G.
Yeah, but aren't those being
correct?
But okay, so I think those might be getting captured back up at number 1.
Yeah, it might not. It might be more than A and B. That's worth looking into. Like, it looks like E might be something different, and F is definitely something different. So there's some pieces that should be left in, but yeah, I probably was too narrow in calling out A and B. So we should just look and see which of those really totally are superseded by the reference in 1 and get rid of those.
Okay, because I see 1 as broad, but again, that's just me reading it. If we need to keep, E's and F's, that's fine too. I thought we'd get rid of 4 altogether if we rely on number 1. So.
Well, so because some of this gets into the NQTLs, which isn't covered under number 1.
Okay.
Like F is an NQTL,
Okay.
G is an NQTL.
That's
so those
fine.
aren't covered by 1.
Yeah, and this is definitely something I need to spend a little more time with because it's the substantially predominantly all test I need to hone up on a little bit before we start removing language, but I will do that before the next RAC.
Thank you.
Any other questions about either this section or any other sections of the rule? All right, hearing none. Does anybody have any questions or comments before we move on to the public comment portion of the agenda? All right. So if any members of the public would like to provide comments, please raise your hand and I will call on you. Okay, I'm not hearing anything. So I'm going to give you all about half an hour of your time back. Just for your knowledge, our next RAC meeting is scheduled for Thursday, July 21st from 1:30 to 3. I will check in with Tim and Dan before that next meeting to see if we're ready to have a larger conversation on the training of providers. And then we can review any changes that are made to this draft rule set. Is there anything else that I need to be thinking about for the next RAC agenda that people would like to see? All right, then. Well, everybody have a great day, and thanks for joining in today.
Thank you.
Thanks, Brooke.
Bye-bye.
Thank you.
Thank you.